join us today. All right. So we also invite everyone to change their Zoom names into the following format. So you can use your name. If you're comfortable, you can add your pronouns, and then also the organization where you're coming from. And so that we can hear each other clearly, we invite our colleagues to mute their microphone when not speaking. And for us to also have an engaging session, we invite everyone to turn on their cameras. So similar to our previous webinars, we encourage the use of emojis and the raise hands function. So you can view them at the bottom part of your interface if you're using your laptop or your phones. You can also use the chat box to type in your questions, or if you're having challenges with the internet connection or having challenges with the technical side of things, please inform us through the chat box so that we can address it. We're also having this session in different languages. So currently we have translators for English, French, Khmer, and Bahasa. So thank you for our partners who are helping us with the translation. And as always, let's make sure that this is a learning opportunity for everyone. So we encourage you to ask questions, learn from each other, and also contribute your insights so that we can make this a very fruitful session for everyone. So I'd also like to make a shout out to all of the participants who are already introducing themselves via chat. So thank you for joining us for this Lessons 12 webinar. Just to also walk you through the different translations. So you can, if you want to listen in to either English, French, Khmer, or Bahasa, you just need to locate the interpretation icon at the bottom part of your interface, and then just select which language you're most comfortable in. So just select the one that you're most comfortable in. Okay, so now let's begin this session by starting with an icebreaker. So I invite everyone to join this Kahoot session. So all you need to do is to scan this QR code or go to www.kahoot.it, and then you can add this pin located at the bottom part of the screen. So that's 416-4311. So once you click and you're able to go to the Kahoot interface, you should be able to see this interface in the website. All right, so are you seeing it? Please also hear the audio so that it can be more exciting. So again, the game pin is 416-4311. Jeff also placed it in the chat box right now. Okay, so I see a lot of participants are joining in. Okay, so there's Beyonce. Beyonce is with us for this session. So let's just wait for some more participants. Currently, we have 50 in the call, so we should be expecting around at least half of it. So we can start. So I'll wait a few more seconds before starting. And let us know if you're having challenges with accessing the Kahoot link. Right? Wow, Charlie XTX is also here. A lot of celebrities joining our Kahoot icebreaker. Okay, so with that, I'd like to start the Kahoot session. So again, the instruction here is that you just need to select the right answer, and the faster that you select the right answer, the higher the points will be. Okay, so first question, which organization connects national public health institutes globally to share knowledge and support development? We have 20 seconds. Is it red, the Global Fund? Is it blue, the World Health Organization? Is it green, the Network for Advancing Public Health Institutions? Or yellow, the National Association of National Public Health? Okay, so majority got it right, but few of us answered the Global Fund and the World Health Organization. So it's actually the International Association of National Public Health institutes. No, so some of us will, one of them will actually be sharing us their work later on in the session. So you'll meet someone from INFI later. Okay, so let's proceed to the next one. Okay, so Anna is taking the lead, followed by Daisy and then Pomelo. Okay, next question. What is the primary role of a national public health institute? So is it red, provide general hospital services? Blue, lead or coordinate public health efforts or approaches? Yellow, oversee private medical practices? Or green, manage national pharmaceutical supplies? Okay, so almost all got it correctly. So the role of a NPHI will be to lead or coordinate public health efforts using science-based approaches. So later on, we'll be expounding on this more during our session. But at least you know the primary role of a NPHI currently. Okay, so Jeffrey taking the second spot now. Anna's still on the lead. Next question. So all of the following are functions of NPHI according to IATI except red, evaluation and analysis of health status, problem investigation and control, green, public health research, and yellow, service delivery. So the correct answer is service delivery because it says accept. So all of the three are actually mentioned in the website of IANFI as core functions of an NPHI. Okay, Anna's still on the lead. Charlie XCX having a streak of 3 currently. Second to the last question. The US Center for Disease Control is an example of an NPHI. True or false? There's 50% chance to get the correct answer. Second, correct answer is yes. It's an example of an NPHI. So later on, aside from the US CDC, we'll be hearing some more organizations that are NPHI later at the Q&A session. Okay, so that's a lot of people got that wrong or took time before they answered. Last question for this. Which of the following is considered an attribute of an effective National Public Health Institute? Is it red, limited public recognition? Blue, independent from government oversight? Green, national scope and recognized government authority? Or yellow, influence limited to local government? Okay, so it's a mix, almost. Some people got confused with this, but when we talk about National Public Health Institute, so it's effective because it's national in scope and it's also a recognized government authority. Okay, so let's look at the winners. So we have Anna from being consistent was third. Santorn was number 2. And then the first one. And then we have Ruby and Pink as coming up. Who's Charlie X here? So congratulations to our winners. And let's go back to our main session. So just to give a quick description of what lessons is. So this is actually our last lessons webinar. But the goal of lessons is to equip participants with knowledge on pandemic preparedness and response through lectures from resource persons and knowledge exchange activities with our country implementers. So as you can see here, you can view the previous webinars in the Lessons Knowledge Hub website. So you just need to go to copper.apcaso.org and then you can look at different recordings as well as the text summary of the different lessons webinars that we've had in the past. So now, I'd like to start our conversation for this session by introducing to you our guest, our the one who will deliver our opening message. So, Dr. Gina Saman is the Regional Emergency Director of the World Health Organization Regional Office for the Western Pacific. She's an infectious disease epidemiologist with a career focused on pandemic risk management. So for over 15 years, she has served WHO at different levels from country, regional, and headquarter levels. She previously worked and consulted for agencies including the US CDC, USAID, DFAT, and DOHA Australia, IOM, RTI International to implement public health initiatives and refugee health programs. In 2022, she was awarded with the WHO Director General's Award for excellence. So without further ado, I'd like to introduce Dr. Gina Saman to give the opening message and set the context for this session. Over to you, Dr. Gina.
Thank you, Arjit. Hello, colleagues around the world. What a wonderful opportunity to share with you and to learn from each other. That Kahoot app was amazing. I'm going to have to download that and play with it and make sure that our future activities have something similar. So thank you to the Global Fund team, A, for hosting, but also for inspiring. I'm going to share with you a few slides, folks. So bear with me as I bring it up, and it's wonderful seeing um, colleagues who are in this um, in this webinar to share and to hear from each other. RJ, are you seeing the right form of the slide deck?
Yes, it's clear.
Good to go. All right, wonderful. So, folks, I'm scene setting. Few slides just to touch on a tone, really. So, over the last few years, we've been seeing an increase globally in the number of countries with a national public health agency, or in some places, they're also called National Public Health Institute, or in other places, they're also called Centers for Disease Control. But the key message is that this is increasing in popularity, nearly a doubling. And what I'd like to say is we get asked a lot, and I can see Dr. Sada from IANFI here with us. We get asked a lot as agencies, what is an NPHA? How do you define it? And so I have a question for you all. Do you like ice cream? So give me a thumbs up if you like ice cream. In essence, I would say that there are many flavors of NPHA ice creams. And the reason is the countries are forming and shaping an NPHI according to their needs. And so some key defining features of an NPHA really is it depends on the national context. And at the core, what it does is bring together essential emergency related preparedness and response functions under a single umbrella, a single entity, and critically, to have a level of recognition, influence, adequate infrastructure and workforce, and accountability. So, what we can see also is the need to focus on function over form. What does it do? And again, that does depend the main, and there may be tensions at some points in what an NPHA does, for example, versus what a Ministry of Health does, or what another authority may be doing. So, all of this to say, it really does depend on context as to how to define an NPHA, with largely a focus on those public health functions relating to emergency preparedness and response. So, how do we think about NPHAs? There are six pieces, as you can see on the in these boxes. There is a piece on capabilities, what they do. There's a piece on their structure. There's a piece on the networks and bringing them together. There's this number four on financing. There's pieces on workforce and the tools that they use. And so when we think about some of these aspects for the capabilities, we're currently actually developing a framework, and we hope that that's going to be available soon. In terms of structures, the governance, WHO and the Health Alliance are currently documenting flavors of the ice cream, 11 different types of NPHA governance models. So we hope to see that published in 2026. And we hope to globally map NPHAs and what they do so that we have a better understanding of what is happening around the world. The networking, talking to each other, the community, COPPA, and others are key. And so there are quarterly series to exchange and discuss. And in fact, in our region, in the Western Pacific, covering 38 countries and areas, we actually even have a WHO collaborating center, the Korean Disease Control Agency, which works as a collaborating center for WHO on NPHAs. And lastly, another piece to highlight is around financing, which again, engaging with different partners, including the G20 task force, pandemic fund is helping countries to strengthen their systems, the Global Fund, and others to, to strengthen NPHAs and their functions. I'm going to zoom in for 1 minute on this number one, the capabilities. And we can think about capabilities again. What do NPHAs do? We can think about them in terms of their foundational capabilities and their technical capabilities. So you can see aspects about legal instruments for effective emergency preparedness and response EPR. You can see around workforce strengthening and development. There are pieces around financing, governance. These are foundational. The other pieces around technical, such as surveillance, such as laboratory systems and diagnostics, such as public health and social measures. And as you can see, the list goes on. My final slide will be to zoom in on one piece that I will say I'm taking the opportunity as being from the Western Pacific region to give you an example of how our NPHAs in our region are doing things that are relatively new in terms of what we have to deal with in public health, and that's around infodemic management. So there's a lot of, as you all know, a lot of misinformation and disinformation out there. We can see most recently a story that Korea had confirmed, allegedly, the link, a study had confirmed the link between COVID-19 vaccines and cancer. And so, taking this information from social media, there is the need to manage the infodemic, right? And so, what we can see here is that the NPHA, the Korean Disease Control Agency, put together the information, provided data, provided analyses, held a press conference that was then amplified by the press and partners. And why I think this is important to mention is it's about showing the role of an NPHA to tackle with science, to work with partners, to put information out there. And it's about saying that there are opportunities to work alongside and with an NPHA. Another example is from last year, where there was, again, misinformation and disinformation around HMPV, human metapneumovirus in China, being the next pandemic. Again, what we saw was that the Chinese Center for Disease Control and Prevention, an NPHA, again, had the data, the analyses, put out a press release through their foreign affairs, and also amplified through WHO to show what is the correct information and that despite the elevated rates of disease presence, this was not unexpected for the season. So you can see here a key takeaway. The key takeaway being that we need institutions in our systems that focus on data, on evidence. They are credible sources of information. They communicate clearly and coordinate efficiently and respond efficiently and effectively. And that no institution does this alone ultimately, which really presents why and how we need to leverage communities to work alongside, with, and in coherence with national public health agencies. These are just some very acute examples that shows the breadth of what some of the agencies, at least in this region, do. With that, I thank you and back to you, RJ.
Thank you, Dr. Saman. I think it was a perfect way to situate our topic for this session. And I like that you emphasize that NPHIs or NPHAs do not only address pandemic preparedness and response, but also infodemic that comes alongside PPR concerns. And of course, for all of the civil society partners that are here, it's also important that we learn how to engage these institutions because you're right, they definitely can't do it alone. So there has to be a strong partnership with the community. So thank you, Dr. Saman, for that. So with that, I'd like to transition over to our keynote presenter for this session, who will talk about the role of public health institutions in PPR. So I'd like to call on Mr. George Kamau from the Kenya National Public Health Institute. So let's give him a round of applause. Over to you, Mr. Kamau.
Thank you very much. Happy to meet everyone. So I think I'll go direct to the presentation. My name is George Kamau from Kenya National Public Health Institute, and I'll present on how Kenya has involved community engagement. Next slide. So this is just a landscape. In Kenya, we have 47 counties where we have the national government and the county government. So meaning these are two forms of government where there is coordination between the national and the county. Next slide. So Kenya National Public Health Institute was gazetted through a gazette notice, which is legal notice number 14 on 21st of January 2022. So meaning our institution is still young and we're still doing operationalization. However, we've started doing our core mandate. So core mandate of NPHI is to strengthen and promote public health functions by providing centralized platform for management and coordination of key activities in prevention, early detection, and management of public health emergencies of concern. Next slide. So our vision is alert today and alive tomorrow, and our mission is to enhance and safeguard lives by defending against existing and emerging public health threats. Next slide. So why NPHI? So number one, before we had NPHI, we had fragmentation. If you look at the image on the left, we have everybody working in silo. But once we have National Public Health Institute consolidating everyone, so we are able to break the silos and also avoid duplication of activities. Thus, we enhance rational use of resources, coordinated leadership, and accountability. Next slide. So these are the functions that are in the legal notice, and I won't go through word by word, but basically one is on outbreak and emergencies. That is one of the core function, and then we need to build a capacity on response capacity. We also need to facilitate appropriate lab capacity to detect and confirm outbreaks, and then we also need to establish public health emergency operation centers, and we also need to manage public health functions during peacetime. Next slide. Um, all right, so the other function is surveillance for priority conditions. So we have routine surveillance for priority diseases, and then we have to develop key messages to the public for prevention and control measures, and then you have to conduct vulnerability and risk assessment tests. Next slide. So the other thing, we need to build capacity for public health professionals. We have a training school that is FLTP, Field Epidemiology and Laboratory Training Program. And then you also have to do M&E to make sure that we are able to deliver on our mandate. Next slide. So the other aspect is on public health research, and then inform policy. We need to have evidence that will guide on policy change and may do policy briefs on the same. So the other thing is support operational research, especially when having outbreaks. We need to carry out OR, and then other functions will be guided by the board. So the next slide. So the next slide is on how many divisions were able to transit to KNPHI, which are 13 divisions. Next slide. Is it my internet?
All right. George, I
Oh,
think we lost you for a bit, but I think you're back.
oh, sorry about that. I think it's my connection, but let me change the point. Are we good?
Yes, we can hear you.
Let me change the internet connection, or I can just proceed. All right, so these are the 13 divisions that were able to transit from KNPHI. So basically, I won't go through, but I'm sure we'll share the slides and we'll have a look at every division that was able. There are 13 divisions in number that have been transitioned to KNPHI for coordination and of different public health emergencies. Next slide. So these are the milestones that we've had from all the way back from 2011 up to 2025, where we had establishment of NPHI as a department in the Ministry of Health. And probably key of note is from 2024, we were able to have government funding to NPHI to support. And on 10th, on 8th May, we had an official launch where staff were officially transitioned to KNPHI. Next slide. So on community engagement and pandemic preparedness, so KNPHI the main role is coordination of national preparedness, surveillance, and response systems. And here we have communities that are in the front line, which is level 1 in our case, where we have the community health promoters. In Kenya, we call them community health promoters, who have households to man on a daily and make sure that they report the indicators on an electronic system. So COPA has been a strategic partner again, supporting grassroots engagement in pandemic preparedness and response. And why community engagement? One advantage of community engagement, we are able to have early detection of outbreaks, which start at the community level where the community health promoters live and work from. So, and then the other thing is trust influences collaborations. Once we have trust from the citizens, this enhances our collaboration or compliance with emergency intervention, such that if we give directives or we give guidance on what to do, there's minimum resistance to that. So the other thing is sustainable preparedness depends on local ownership. So meaning if there is local ownership from the local gatekeepers, the chief, the people, the leaders at the local level, it's easy to sustain the program because there's ownership at that level. And preparedness is only as strong as the community at core. If there's ownership and trust in that system, then there's opportunity to have the system running at the community level and ownership. Next slide. So community roles integrate. How do we engage communities? One, in prevention, we are able to do mass drug administration, whereby we able to give drugs in schools together with the Ministry of Education in school health programs, where we are able to do elimination of neglected tropical diseases such as schisto, lymphatic filariasis, and the soil transmitted illness. So at this level, we are able to engage the community in mobilization in even reaching out households to make sure that every member is reached. And in surveillance, I think the community health promoters, we are able to engage them, even the traditional healers, even the vets, such that they report on any unusual event. If they see animals that are dead or any unusual event in the community, they are able to report that in the system where it's picked as a signal, and we thus have to verify the signal if it's true or false. So the other thing is on response. Once we have a confirmed outbreak, we also engage the community, because it's easy to know the households and even maneuver the community when you're having the community health promoters who are easily known and acquainted with the ground. So we are able to use them to be able to do our response activities and at the same time do our recovery activities. So the other thing we're able to do is community-based surveillance. So there is something we call CBS, the community-based surveillance, where we are able to involve the community health promoters and animal health workers to identify and report on any priority diseases, which the system is linked to integrated disease surveillance system and DHIS2, which is an electronic system that they use tablets to report on. And the system, we call it in Kenya ICHIS, which is Electronic Community Health Information System. So example of where we got a true case scenario was a case where we got Rift Valley fever, which was reported as a signal from the community in Garissa and Kajiado. So we were able to pick this signal from the ICHIS, and it was confirmed to be RVF. So the other area is on risk communication, where we have faith leaders and influencers and the imams, where we are able to even use the local radio stations and social media. For example, in a county in Kisumu, we used community influencers, and we are able to reduce vaccine hesitancy, where we had some people having infodemics or misinformation about the vaccines. Next slide. So the other one is participation on preparedness and drills. So case example, we have a county at the border called Bungoma, where we had a simulation exercise in 2023 on Ebola. So these were joint drills where we do the county health teams, and the community is heavily involved in these activities, so that there is also ownership and knowledge when we have preventive measures and what to do in case we have an outbreak. They're also enlightened and part of the drills. So on One Health, we are able to detect anthrax early. That was in Nakuru and Turkana, and this again was reported by the community. So meaning we really need the community. They're like the backbone, and they're they're the first responders, and they're the people who give the first signal, where in return we are able to confirm and verify the signal is true or not. So the other thing is on community data and feedback loops. This is quite important, where we have mobile tools for real-time symptom reporting and community scorecards on the service delivery, where you're able to say how the community is performing. And this example is in Makueni, another county, where we have dashboard integrating with community data, and we are able to get real-time feedback on the same. Next slide, please. So on community advocacy and accountability, we have the civil society working with us. We have synergy with the civil society, where they're able to push for budgets, where we have budget cuts from the exchequer and inclusion of the marginalized groups. And an example is where Kilifi Networks was advocating for vaccine equity, which came in handy from the civil society, and we were able to get that agenda. Again, on social and behavioral change, we have core design studies on behavior and risk, which informs RCCE messaging. So we are able to give targeted messages depending on the need. And a case example was during COVID-19 study in informal settings, which was done between NPHI and AMREF in 2022. So volunteer networks and resource mob, we have youth groups engaged on logistics, on tracing and outreach. And a case example is another county in Nyeri, where we had the Red Cross youth during contact tracing of our clients. So feedback and grievance channels, I think In 2024, we had a toll-free line, and we also have barazas. Barazas where we go and meet communities and have a focus group discussion. And we also had a WhatsApp for reporting where we were able to integrate that and we could get real-time information the same. Next slide. So inclusion and governance, we have community reps, especially in the Turkana is a far-flung county where it's quite extreme. The weathers are extreme, and we have pastoralist communities. So in this county, we have the pastoralist reps being represented in the county emergency committees because they're able to pass the message to their counterparts in the community when there is movement and when there is engagement. So we're able to also to engage the community in governance. So for public health research and monitoring and evaluation, we engage community through community dialogues, where we still have the barazas, where we said that is focus group discussion and stakeholder forums and interviews before and during data collection and dissemination, where after we do report writing, we do co-create research strategies and policy documents for effective implementation. So in a snapshot, I think what we've gathered from the community, we are able to have 30% faster alerts when we engage the community, because primarily they're the first responders on the ground when they meet all these events. And then there's trust and compliance, and that was indicated when we had higher vaccine intake. The other day we had mpox vaccination, and we also were able to pass our targets because of involvement of the community. And then we have local ownership. So the community-based surveillance is integrated in the counties. They are able now to plan and integrate in the county annual work plans. The other thing is sustainability. We have stronger community and government collaboration. So as a country, we have been able to set a budget to give stipends to our community health promoters. So meaning they're on the government payroll. So there's a good collaboration between the community and the government at large. Next slide. So lessons learned is engagement must be continuous. This is a continuous process that must be enhanced so that we are able to meet day-to-day needs and be able to also to adjust to the needs at hand. So then the next one is local structures need resources. We need financing for local structures. And the other key thing, we need a two-way communication. We need feedback. Once we get diseases in the community, we get information from the community, we need to have a two-way feedback mechanism that community is involved and they appreciated and they have knowledge of the like the outcomes of the diseases on what happened, resource allocation, resource utilization, so that we are able to gain trust from the community. So I think the other one is building trust as a vital as building labs. The way we value building labs in Ministry of Health, I think building trust is quite vital for the community. Next slide. So challenges are limited funding for long-term systems. We do appreciate this project brought in funding. But for long-term sustainability, I think we shall require government ownership and allocation of resources. And this we can only do with evidence that will be generated from these projects to be able to advocate for change and even resource allocation. So it is our sincere hope that these challenges of funding, the evidence generated from these projects can be used to change, to give a paradigm shift to the way government funds and have resources allocated to the community. So the other one is on digital reporting gaps. I think we need to enhance. We started with this, but we still need to enhance and be able to have interoperable systems and also be able to have real time. So it's not 100%, but this is an area of an opportunity for strengthening. So with coordination between sectors, I think working in silos, having TB program, having malaria program, having HIV program, working in silos, I think we need to have coordination between the sectors to basically have even rational use of resources, not have different community health promoters for each disease, like by silo disease, but have an integrated form of community health promoters. And next slide. Opportunity, we have to scale up the community-based integration. We need to support for digital tools for real-time data. And then we need to strengthen county One Health networks because we need to look at disease, or we need to have a One Health approach where we look at the animals, we look at the environment, and we look at human health. So we need to look at everything in a One Health aspect, and then the other opportunity is build capacity for behavioral science, where we can even engage the anthropologists. Next slide. So next step, I think we need to develop a community engagement roadmap. And then we need also to document and publish the best practice that we got from this project. And we also appreciate the meeting that we had in Ghana, where we had peer-to-peer exchange, where there was a lot of learning, and we really appreciated to be part of this engagement because we also were able to take home key areas of improvement. Next slide. My conclusion is borrowed from our meeting in Accra, where the Nigeria team said, health is too important to be left to medical professions only. So this was a wake-up call for me, and that is my conclusion for today. Next slide. Thank you. The next slide should be thank you. Thank you very much.
Thank you, George, for walking us through positive feedback from the chat. But your discussion is that when we talk about NPHI, it's a integrated way
Sorry, I
front.
think either my signal or yours is not okay.
I
I
think it's
keep
RJ's. It's RJ's internet.
keep breaking. Yeah.
Hello, everyone. I think we lost RJ for a moment.
Hello, can you hear me
Ah,
now?
yes, we can hear you now, RJ. Please go ahead.
Okay, so thank you, George, for walking us through the presentation. I think I share the sentiment of the people in the chat. We're getting a lot of positive feedback from your presentation, and I think when what I picked up from your discussion is that when we talk about NPHIs, it's a more integrated way of delivering public health functions. And I particularly like how you describe the role of the community health promoters, where they basically assist in different areas of work, particularly on the early detection of diseases, um, making sure that they're also onboarded with research work, resource mobilization, as well as communications work. So I think that was particularly instructive, especially for the civil society organizations that are yet to engage their NPHIs in their specific countries. So thank you, George, for delivering that presentation. Okay,
Thank
so
you very
now
much.
yeah, go ahead, George.
Thank you. Thank you very much.
All right, thank you. So hopefully we can still hear from you during the Q&A because there are a lot of questions about your presentation. So a lot of people are interested. Okay, so now let's proceed to the next part of our discussion, which will be a sharing of country level experiences on how these civil society civil society three gentlemen who will be sharing their experience. So we have first Chantorn Prong from Cambodia. So Chantorn is the manager for policy, advocacy, and resource mobilization at the Khmer HIV/AIDS NGO Alliance, or CANA. We also have Paul Bangura from Sierra Leone, who is the National Executive Director of the Civil Society Movement Against TB, or CISMAT SL. And lastly, we also have Dr. Leo Tia from Liberia, who is the founder and executive director for the Youth Network for Positive Change. So we'll hopefully we can have them in the screen now so that we can have an engaging conversation. And basically, from these three panelists, we'd like to ask them, how are they able to engage with their NPHIs, or if they don't have the NPHI yet, the Ministry of Health, and how are these integrated in the PPR processes? So I'd like to call it first Chantor to answer that question, and then Paul followed by Leo. Go ahead, Chantor.
Thank you so much, Archie, and hello everyone. It's Chanton from Kana, and thanks for having me in this important session. So I just want to share our engagement in PPR in our context. I mean, in Cambodia, we started with the HIV TB program, and then right now we have expanded our engagement in how to say pandemic, in a broader way. So through the Cooper CE project, I mean, before the Cooper CE project, we started, producing an evidence base. It's called strategic information to explore or to identify, a group of last mile population in TB program. So that's why starting from then, we identify one group who is a last mile population for TB program. It's called internal migrant worker. So after that, we understand that the last mile population not only in TB context, but I think we thought that it should be under other program like HIV, like malaria as well. So that's why we expanded our focus to other program. Just to let you know that the last month population that we did under the curl, the result from the assessment right now has been included in the KP site estimation for the national TB program. So we conducted an assessment, we have a specific findings. So that's why right now it's been integrated, it's been included in the KVP site estimation. Beyond the HIV program, like I said, right now we also engage with the CDC, Communicable Disease Control Department of MOH, because this particular department or program, cover pandemic, So that's why we engage with them. So, but however, we started, with our collective voice. Collective voice, meaning that we, how to say, kind of supported, to establish a platform. It's called Pandemic Preparedness Prevention and Response Platform, which is known as a community and CISO-led platform. So this platform consists of, 30 members individually from community network of HIV, TB, malaria, and the another government side. It's called Cambodian Youth Red Cross. So as well as CSO working on 3 diseases, HIV, TB, and malaria. So we need to have a physical structure. And then building on the platform, we introduced the platform to the CDC MOA. So that's why we we engage with them and also ask them to share to share with us around IHR, international health regulation, joint internal evaluation, SPA, as well as enough. So that's why we see the progress and country progress and how the CSO community can engage with. And then after that, they recognize, the platform, the mandate, the representation of the platform, being a CSO and community platform. So the CDC recognize and acknowledge us. So, and then they engage, they keep engaging with us, when we organize, we do something around pandemic, they engage, they join us and also support us. And one important thing is they requested, they wish to see community and CSO have a specific role, in supporting the implementation of the National Action Plan on Health Security. So they request this community CSO to deliver or to cover, specific area. There are 7 specific areas that the government, the MOA, want the platform or community CSO, to focus. One is about the RCCE, risk communication and community engagement. That's the first one. Second is about the community-led surveillance and early warning system, and what the roles of community and CSO, can take part, when the pandemic, or even, happening. The third is about the health delivery, mainly focus on continuum of care when the pandemic happened, what the roles of community and CSO, can support. And the fourth is about the advocacy and accountability. Fifth is about logistic and humanitarian support. 6 is about inclusion of marginalized voice, meaning that who are left behind, to include in the system, health system. And the last one, and very important, like George, our colleague just mentioned, is about research and data collection. I think these 7 areas focus are useful and also concrete point that CSO and community, can take part and support the implementation of the NAF. So I think right now, just to let you know that because of our engagement, the CDC MOA, they are doing, or they are developing the infodemic management SOP. And then they invited us, a PBR platform member to join. Right now, it's still happening right now. And then we also support in, how to say, providing technical input as well as, to inject, some part around community engagement, also engagement. It seemed to be missed when, but when we joined, we provided, specific comment or suggestion. I think this, how to say, the background, the experience that the community CSO, engage in the national HIV/TB and malaria program, as well as the CDC, MOH. I think that's all from my side. Adi, how about you?
All right. Thank you, Chantorn. And I'm also wondering if can you if you can also describe the role of Copper and how it actually helped with the setting of the platform, the facilitation of the engagement with the CDC and MOH. So maybe you can speak more about how Copper was actually helpful for you and your organization.
Okay, thank you so much. The corpus can help, like I said before, we come from individual program, meaning that HIV, TB, and malaria. But when we started, implementing Cooper, we came together to how to say, to create like a coalition or platform. So it's mean that a collective voice. So that's why all voice from 3 diseases come along or come together. So I think this a good mechanism. And then after that, we bring the voice of CSO as a collective voice to the CDC. Let's see. This is not only specific program, but across program funded by the Global Fund and beyond that. So that's why they start recognizing, they start acknowledging, oh, it's very important to have, because this can be representing like a community, because they said, the IHF of call point, from the MOH said that before they never had any representative from the community or CSO, only the CSO from the zoonotic disease, but for the human health representative, they said that, so that's why this they assume, or they, how to say, they recognize our role, our representation. So that's why I think this is very important. In addition to that, we need to ensure our platform member are aware of, specific topic around PPR. So that's why we capacitate, our member with PPR knowledge or concept, with IHO, some part of IHO, and also the GE or SPA process. I think these are also very, very important. And then I think this is like, how to say, the connection meaning that when we are ready, we have something, with And then if they need something from the community side or CSO side, so that's why we come together and exchange or share and how we can support, to the CDC if they need. I think this is how to say the background or the connection between the Cooper or PBR platform and the CDC.
All right, wonderful, Chantor. And what I'm hearing from you is that Copper was actually instrumental in terms of consolidating the fragmented civil society before that are siloed from one disease to another, and now you're more united and you engage more proactively. But of course, there are continuous capacity building efforts that should be done to make sure that that continues, right? And I think it's also good that you have a more you have a tighter way of tighter way of sharing expertise with the government as well as civil society. So that's good. So thank you, Shattered, for walking us through that.
No.
So now I'd like to turn the conversation over to Leo from Liberia. Leo, are you in the call?
Yes, I'm here.
All right. Thank you, Leo. And I'd like to start this discussion by asking you on how you are currently engaging your NPHI, and then we can go to more specific questions afterwards. Go ahead, Leo.
Okay, thank you so much. Hello to everyone. It's good to be on this call. Um, as our implementing partner on the Copper CE project, we have been actively engaged with the Ministry, the National Public Health Institute of Liberia, and the Ministry of Health. So when it comes to the Ministry, the National Public Health Institute, initially there has been limited community engagement or involvement with the institution. But given the role of the Copper CE project, amplifying community voices, representation, participation in PPR processes and structures. So we have been able to engage through the Public Health Institute. When Copper started, actually, we were at a transition point in Liberia where there was a regime change. So definitely there has been new appointments made to the National Public Health Institute. So it was a bit difficult from the beginning to engage because even those who were taking over at the institute were new and they needed to connect, engage, and have more information on communities. So we have so many engagement meetings at the local level, at the agency, and also at the highest level, which is the director, who also participated in the launch of the Copper CE project. He was the chief launcher of the Copper CE project. So that gave us a leverage at the very beginning of the Copper CE project. So because of that, it opened doors to more engagement and participation. And that's how communities and CSOs started actively engaging and participating in the technical working groups meeting at the National Public Health Institute, where they provide updates on all emergencies and response issues in Liberia, and also engage the citizenry as a whole. So these are some of the successes we have been able to accomplish through the efforts of Copper CE project, and especially engaging. And now we have the One Health Governance Manual that was developed by the National Public Health Institute that is has direct oversight under the office of the Vice President. Now, in that manual, we have a clear rule of civil society, their roles within the structure of PPR in Liberia is clearly spelled out. And then also, that manual is above all other pandemic preparedness and response document in Liberia. It is at the highest level, and communities were able to participate in the review, the development, the review, and the validation of that key document. So it tells you to the level of which communities now has reached in terms of representation and participation in PPR processes and decision making. That's just NPHI, same for other agencies, but we're discussing NPHI here today, the National Public Health Institute. So yeah, these have been some of the efforts we've made. And also through the Corporate CE project, we've been able to also develop our community representation guide, which has been involved again with the same Public Health Institute, the Ministry of Health, and all other stakeholders. We have developed this guide also clearly outlining communities, their representation, how it should be in these various processes also. Just a complementary one to the already existing One Health Governance Manual. So thank you for my end for now. I look forward to follow questions.
All right. Thank you, Leo. And I think what I'm also picking up from you is that right now the Copper platform did not only ensure representation, but it somehow also contributed in transforming how you relate civil society with your government. So that's really good to hear. And recently, I researched on the internet that Liberia NPHI was recently awarded as a Center for Excellence under the Africa CBC Regional NPHI Capacity Strengthening Initiative. So congratulations to uh, the Liberia NPHI. But we're also interested to know, Leo, with this award, of course, we also need to make sure that their efforts are sustainable. So maybe you can also speak more of how do we actually measure the effectiveness of community engagement, and also, is there a way to ensure that it's sustainable in the long term? Because you mentioned that there were administrative changes before, so maybe you can also discuss how it transitioned.
Okay, thank you. So I think basically it's about uh, ownership to a greater extent. And that's why in my closing statement, I talk about the representation guide that was recently developed, that is a more sustainable approach, because even the governance manual is for a certain period of time, and afterward there is a need to update. But the representation guide, even though it can be updated, but it's going to be a more permanent way telling all stakeholders how CS and communities can be engaged. So that I think show ownership, because the way it was developed with the involvement of communities at all levels, and also these various agencies who are responsible for these different PPR processes and structures. So, and now in that manual is more detailed, even beyond the national level, going down to the very local level, looking at the community health volunteers, looking at what we call here the health facility development committees. These are all governance structures at the very local level for emergencies and or health as a whole. So also, NPHI also look at uh, for moving forward, some of the indicators we're looking at is the meetings, how many meetings community are participating, how many structures they are part of, how many issues are they raising, as are there issues being considered in those meetings. So it's not just a participating and being seated at the table, but also whether they are also being heard. All of these things are clearly stated in the manual, and what role CSOs can also play at the community level in terms of coordination and trying to give feedbacks on the various processes as to whether they are effective and moving in line with existing principles and regulations. So I think in that way we can say it's sustainable, and also looking at through the COPA we have established a coalition which have agreed to continue as a coalition beyond the scope of the COPA CE project. As we all know, COPA is drawing down, and this coalition is still existing and is moving. So communities now taking ownership of response, preparedness, and following up. So I think with all of these different efforts, there are more way to measure, and then also looking at the long term and the short term impact, and also looking at integration into national systems, looking at local ownership, and promoting innovative ways to continue the efforts even beyond the existing gains. So I think these are just few that we can speak to for now. Thank you. Over to you.
All right. Thank you, Leo. I think what's important, one thing that he mentioned that is important is the importance of institutionalizing civil society participation. And they effectively did that with the One Health governance manual. And even after the funding will not be continued, I think for copper, there's continuous buy-in for the community. And I think that's a display of a deep ownership of the different coalition members. So congratulations to Liberia for continuing your work. Okay,
Thank you so much.
thank you, Leo. So now I'd like to call on Paul Magura. Are you in the call?
Hello, I'll be presenting or talking on behalf of Paul, the National Executive Director. I'm Mohamed, the Program Manager for CISMAT.
Okay, go ahead, Mohammed.
Maybe he will join us as we go along.
All right. Okay. No worries about that. But maybe you can also share how you're engaging with your NPHA in Sierra Leone, Mohammed.
Yeah, thank you very much, RJ, and thank you to everybody for this call. It's indeed an insightful moment for us, though the project is about to close now. Sierra Leone has been part of this project since the CLG coming to copper, where we are ending now. I think pandemics has continued to threaten global health, and not only global health, but economies around the globe. So strong national systems and key to rapid detections and response is very, very critical. So when we start the CLG, when we start to engage the National Public Health Agency, we start to engage the Minister of Health and other critical bodies, WHO, the CDC unit in Sierra Leone. It clearly shows that community participations, CSO engagement, we are not critically involved in terms of their voices being heard, in terms of their aspirations being heard, and also even participating in terms of decision-making come down to implementation. But because of the CLG project, when we start engaging, so many things comes out that shows that community participation is very, very limited or very, very low. And when decisions are made, they are not part. But when it comes to implementations, these communities are the ones that bear the highest burden when pandemic hits. So when we start the engagement, these are the things that came out clearly. So what COPPA did was for us to continuous engagement on this platform, making sure that our voices are heard, our aspirations are being captured when decisions are made or when discussions are made. We noticed that there were only 2 or 3 NGOs. These are NGOs that have been involved in doing things around pandemics. We say no. Why the voices of these lower cadre of people that we call the vulnerable people, or maybe how to reach communities, are not participating? So we started engaging the National Public Health Agency. You know, Sierra Leone experienced the Ebola outbreak in 2014 and also COVID-19 in 2020. So from the Ebola outbreak, the lessons learned from that one is that for Sierra Leone to have a coordinating unit, at that time, there was no National Public Health Agency. The government then established what they call the EOC, that's the Emergency Operations Center, that we are coordinating the activities of the Ebola then. So when Corona struck again, there was no National Public Health Agency at that time. So the lesson from Ebola, the lesson from COVID-19 informed that we should have the coordinating unit. The coordinating unit is the National Public Health Agency that is primarily focusing in coordinating pandemics or any threats that Sierra Leone will have, either in the future or currently as they are managing currently the mpox response in Sierra Leone. So when we engage them, they have a document called the National Action Plan for Health Security, which is the NAFS. We notice that there's not much in that in terms of CSOs and the last mile population's voice being heard. So because of our continuous pushing, continuous engagement to the CELG and the Copper project, we are able to break through. And fortunately for us, they were reviewing the National Action Plan for Health Security. We are almost at the end now, but because of our engagement, we were able for our voice to be heard and included. And at that time, because when the project started, we invited the Directorate of Disease Prevention and Control, is no less a person by Dr. Suleiman Lako, who did open or launch the project for us. So the entire cadre of the of the Minister of Health, we are well informed about the Copper project. Starting from the CELG and the Copper project, they were well informed. So when we want to engage the National Public Health Agency, we pass through the Directorate of Disease Prevention and Control, which easily open doors for us. So when they were at the end in terms of concluding the review of the National Action Plan for Health Security, our voices have been heard, where we mention about equity, human rights, gender, we are clearly captured, and we also make sure that when it comes to implementations, the community that highly negatively impacted during pandemics are part of the process. And not only voices be heard, when it comes to implementation, you should be part. So the Copper project and the CELG project has impacted positively. You know, we have already created a coalition, and this coalition is functioning now because of the Copper support. We have also able to develop an advocacy manual recently, and this advocacy manual will guide the coalition that has been set for Sierra Leone to continuously engage these stakeholders in terms of pandemics, and whenever we have shocks in Sierra Leone. So, and the coalition is being selected across the 16 districts of Sierra Leone. So every district has been represented, and every community, talking about disability groups, talking about women, talking about youth, talking about people living with HIV, TB, they are all part of this coalition. And whenever we are going out for engagement, this coalition will sit and try to have the right people that will represent the coalition in short meeting. So I think the CELG project and the Copper project have really positively impacted Sierra Leone, and these gains that we have made since the CELG and the Copper, we are pushing now for the next coming GC8 grant to leverage from this gain and sustain this gain going forward. And not only the GC8 grant from the Global Fund, we are pushing nationally also for us, for government to own the process going forward, because the gain that we have made, we don't want this gain to die down. We really want to sustain it. And because we are now working together with the central government, I think it's a critical role for us to maintain and sustain this gain going forward. I don't know if the director will come in. Yeah, I will stop for now for further question from you, RJ.
All right. Thank you, Mohammed. And I think it's always very important to infuse the different lenses that we use into government processes. And one way to also sustain that is through the development of the advocacy manual that you developed. I also see here that Paul is already joining us in the call. Maybe, Paul, would you like to add to what Mohammed said earlier? I understand you're having challenges with internet, but if your internet would allow, you can also share.
I
Okay,
think he's
so
doing that in the chat box.
Yeah, so I'll just try to read it. So Paul said here that the TWOTAs also helped us in connecting with PPR national stakeholders. So it positioned them very well for engagement. So I think that's one of the benefits of copper. Mohammed, would you like to add?
Yes, I think more so because of our recognition now, there was a regional platform where CISMAT, as the coordinating unit for Sierra Leone, has been also involved in, because we during our meeting we invite the Minister of Finance, and we all are aware that the Ministry of Finance are very critical unit or component in every country for sustainability going forward. So they invited us in their meetings, and that meetings have also borne out that Sierra Leone CISMAT is part of a regional platform where we normally meet when they have meetings. It's because of the copper interventions. It has made us known more, and also we have known now which institutions to be partnering with going forward in terms of pandemics and response in Sierra Leone.
All right. Thank you, Mohammed. And on the chat, Paul also mentioned here the district level coalition is involved with DHMTs in PPR discussions.
Yeah. You know, I make mention about the 16 districts we have, and the coalition members are all cut across districts. And each district is being governed by the district health medical team, that the DHMTs, and these DHMTs have their own units, which they are also part of the coalition team, because whenever we have meetings at national level, district level, we make sure that we invite the risk communication pillar at national level, we invite the risk communication pillar at district level, even at regional level. They are also part of our meetings, because when we are discussing health issues, these are critical partners to the process. Whenever pandemics breaks, either at district level, you know, Sierra Leone is bordering with two countries, Guinea and Liberia. So whenever we have pandemics within our bordering countries or neighbor, either like, for example, in Kenya, bordering Liberia, the risk communication pillar will be in constant touch with the national pillar, and where CSOs also play critical role in terms of surveillance and information. How do you talk about information giving or sharing out whenever we have pandemics or epidemics? Because of we don't have structured coordinating unit at that time, information will be given haphazardly, and because of the copper project, and when pandemics breaks, now we coordinate as CSOs, and we make sure that information given out is well coordinated, well informed, data driven for the National Public Health Agency before it goes out.
All right. Thank you, Mohammed. And thank you also to our country sharers for sharing their perspectives and their insights in terms of working with NPHIs. So now I'd like to call on Dr. Sadaf Lines from the International Association of National Public Health Institutes to give a quick comment on the discussion so far. And then afterwards, I'll call on Dr. Sulaiman Lako from Sierra Leone. Dr. Lines?
Thank you. First of all, thank you so much for the invitation. I have been so impressed and humbled by the discussions that I've heard, the presentations, the fantastic example that we had from Kenya National Public Health Institute, from Dr. George, and the comments that we've just heard from Cambodia, Sierra Leone, and Liberia. And of course, the copper project. I mean, it's really heartening to see how you're advancing that community engagement, that link between National Public Health Institutes. So just a little bit about IAMPHI, I think. So IAMPHI is the International Association for National Public Health Institutes. We have 127 members over 108 countries. And just picking up on what Dr. Gina said at the beginning, it's that ice cream, different flavors of ice cream. So obviously, you know, we recognize and we work with NPHIs in all different formats. Some of them have NCDs as well as communicable diseases. Some of them only deal with health protection and health security issues. And so for us, it's around country context, which is in country context and governance structures in which National Public Health Institutes functions. So what we are moving towards rapidly is looking at the all hazards approach to pandemics and epidemics. So moving away from just the infectious diseases or even like the One Health approach, but embracing all the other types of hazards that happen within countries that impact human health and the role that National Public Health Institutes play. Again, Dr. Saman was talking about that no institution does this alone. So for us, it's about how does the National Public Health Institute operate within a health system? And then how can we operate within that resilience or build that resilience of that system in terms of normative practices, which are so important. You know, you can't get to a health emergency and then think, oh, we need to engage with the community, or we need to engage with civil society organizations. We need to bring our academic partners along. We need to talk to the police, you know, municipalities. We need to be prepared, and we need to build those solid structures, those networks, those collaborations, partnerships with those key stakeholders across different sectors. So IAMPHI as an organization operates through peer-to-peer. It operates through the communities of shared practice, and it operates through the advocacy for the National Public Health Institute strengthening in terms of their capacities and capabilities. So within that, we work with our partners. WHO is a key partner for us, and we've done quite a few pieces of work now in terms of strengthening health emergency systems within National Public Health Institutes. Community engagement is a key area of work that we are very much focused on, because we do see that disconnect sometimes happening within National Public Health Institutes that sit up there. Obviously, it's to do with scale as well, scale and scope within the country. And how do they engage in a feedback loop mechanism, taking on board collaborative research, collaborative surveillance, strengthening those areas of work. So that's what our main focus, or one of our focus areas, are on at the moment. We're doing this through looking at the lens of connected leaders. So the importance of establishing, maintaining, and sustaining the connected leaders networks from national, subnational to community level, which we think is really, really important to ensure that we, you know, as we've said, actually outbreaks happen in the communities at community level. And what we don't want to happen is for that to get to a national emergency. We want to be able to work together in an interconnected, collaborative way to be able to stop that from spreading. Same thing with cross-border alliances that we're trying to develop within that. So I think, you know, that is really what IAMPHI strives for. And more our work is means that we have to engage across the sectors. We have to bring those sectors around the table, and National Public Health Institutes need to work and do work across the sectors to create that robust evidence that we can translate into policy and advise decision makers in terms of what are the right evidence-based approaches to risk communication, to community engagement work, to public-private sector engagement for preparedness and response systems. So really, IAMPHI as an organization wants to work with you And we have our partners here. We've got our NPHIs here, who are part of IANFI as well. So these kind of webinars are fantastic because we can hear the work that other organizations and countries and NPHIs are engaged in. So I just wanted to say that. So thank you so much for providing me with the opportunity as well to say a few words.
All right, thank you, Dr. Lyons. I think that gives us a deeper perspective of what Ayanfi is doing. And it's interesting to also hear about your all hazards approach to working on different public health threats. And I think really a network is really key, linking government, civil society, and of course with the support of the ANFI and our international development partners. So thank you for joining us for today. Okay,
You're
so
welcome.
now I'd like to also invite in our virtual stage our one of our previous speakers in our previous webinars, Dr. Sulaiman Lako from the Ministry of Health in Sierra Leone. Dr. Lako, are you with us in the call?
Yes, I'm in the call. Let
All
me
right.
say good morning, good afternoon. Let me say apologies. That's because of the bandwidth of the internet. I will not be putting video. Let me thank Mohammed for narrating very well on our engagement in Sierra Leone with the communities, and also Reverend for adding on to that. Now, we have experience, as already explained by Mohammed, the experience in terms of the challenges not working with the community. In 2014, 2015, when we had the largest Ebola outbreak to date, initially government felt it was just a health sectoral issue. It is not an issue that has to bring in different entities, including the community. And then we started the fight, but it was quite challenging until we have to say, oh, there is a community. Outbreaks start in the community and ends in the community. So that consideration brought us as a government say, oh, we need to engage the communities. And when we engage the community, we really saw the importance of that, how we are able to contain the outbreak. But that was a good lesson that was learned. However, the implementation was a challenge, even with COVID, in terms of bringing in the community robustly, in addressing some of the gaps that we do have. But we are better than it was during Ebola. One of the gaps that I saw generally in my engagement with the CISMA team on the Copper project is that there is segmentation in terms of community engagement, despite the fact that we have had multiple outbreaks, and beyond outbreaks of high-risk infectious diseases, we do also have natural disasters, for example, mudslide, the issues around fire incidents, all those ones. But our engagement was not more broadened when it comes to those communities that are down there, that experience some of these challenges. We're also looking at people that are at high risk, those that are vulnerable. So often, even the issues around equity were a challenge, in terms of bringing that. And what Mohammed Samura was trying to say, even the NAPS, they will mention the participation of civil society organizations. And those civil society organizations are high-end civil society organizations, not really those that are working with community people, those are affected by the diseases, those that are at high risk. So these are all the gaps, but with that engagement, what we are able to do is to see how best we can reflect on these essentials. I call them essentials because they are very critical. So first to say, oh, we still have this document. It has not been finalized. And what do we need to do to make sure that these essential domains are integrated into that? So one discussion that comes up is to say, okay, how can we now devise interventions in line with those ones? So we look at issues around equity in relation to pandemic preparedness and response. And we look at issues around human rights, gender, even the gender issue that is very critical, despite the fact that we have Gender Empowerment Act of 2023, but the aspect of implementation was also a challenge. All those components, those bits were left completely. but we are able to advocate and we are able to incorporate those issues, embed them within the National Action Plan for Health Security 2025 to 2029. So there is that opportunity now for us now to push with the advocacy. I know the concern that is raised by Reverend to say, oh, what is the sustainability moving forward? But that provides us a platform to say, oh, we need to engage moving forward. We need to see how best we can now implement those things that we all agree that they should be part of the NAPS. We do have a gap during the process in the area of the One Health Governance Manual. Certainly, when you look at it, there is no component that talks about community technical working groups. We can see different communities. So we look at entities around the One Health, leaving out the community that is very critical. But people now say, okay, oh no, this we have arranged, we have addressed this at community level. At community level, we establish One Health coordination units. I said, okay, that is fine. Well, what is now at national level where policies are made? How can we now bring this? And the One Health Secretariat was very clear to say, okay, this will be taken into consideration. If we are going to do a midterm review of this document, we'll see how that component can be embedded because it is very critical. So we don't want communities to only be engaged at lower level where we have now made our policies and then to take those policies, but rather have a bottom-top approach. So that has been one of the things that with the work of CISMAT and the COPPA project, we have been able to achieve. The other thing is the haphazard nature of engagement of different community actors as well as CSOs. It is good for the communities to be empowered. A lot of structures have been set up at different levels to make sure communities are empowered. Well, that is not the case. And this is because at national level, what we have structures that work independently. You may have a CSO working with, let's say, people affected or living with TB, another CSO working with those that are affected by Ebola. So it is something like that, not well coordinated. And one of the greatest recommendations is for the CSOs themselves to form a coalition, looking at three components. One, the aspect of pandemic preparedness and response, which can also be expanded to include other emergencies, as already alluded by SADAF. But also look at the primary healthcare component, which is very important, and the One Health framework, so that they have that broad spectrum, not allowing the government to also struggle on who to engage. In one of our engagements with the National Public Health Agency, they were very clear that, oh, there is a lot of opportunity even in the pandemic front. And this is an area that I also want to challenge my colleagues beyond the COPPA project. How can we continue with those engagements? I think is very much important. But generally, we have been able to register a lot of success on this. And now we are fine with the process to say we need to be very robust moving forward to hold these people accountable, especially what is embedded in the different documents. So currently, the health sector strategic plan is also being reviewed. And if we look into the health sector strategic plan, government commits 5% of the total budget of the health sector into communities. But whether this is implemented or not, those are things that we as community members now need to see that we hold government responsible, work with them so that that is implemented. In my advocacy, I also pointed that, yes, after this process, we really need to see to the communities to understand how their engagement has been. That is one. But second, for them to be part of the process for development of National Health Sector Strategic Plan 2026 to 2030, because it's very vital. So this we felt is very much central. But I want to thank CISMAT and ACT for this process, for enlightening us, trying to understand, increase our advocacy strength with the information that we have. So look forward to continue to work. And I like the advice to say we have to expand. Look at health as an entity that goes beyond just infectious diseases, but other emergencies, as well as the primary healthcare level. Thank you.
All right. Thank you, Dr. Laco, for that intervention. And I think a lot of people resonate with the importance of really engaging the communities and sustaining the efforts. So now, due to the interest of time, I think we can only accommodate a few questions for this session. But I'd like to pick the question from Lizzie first. Regarding
Sorry, RJ, if I
yeah.
can just maybe disturb, if we could have Anna to say, just give her remarks, because I
Okay.
think there are other things that need to be done, and then we can continue with the conversation. Thank you.
All right, so I would like to call on Anna Malson from the Global Fund to give us a quick overview of lessons and some messages before we end the Lessons 12 webinar. Over to you, Anna.
Thanks, RJ. Sorry to ruin the flow of the conversation, and I hope you can continue to discuss and talk. This has been a really fantastic webinar, and I just want to take a moment to appreciate everyone and your contributions to really highlighting the role of National Public Health Institutes and how communities remain and still are the heart of pandemic preparedness and response. And what COVID taught us really was that trust is not built in a crisis, it's built before one. So everything that we've been working on and continue to work on is continuing to lay that groundwork and the foundations about building trusted, responsive systems. And I really like the tagline in the Kenya NPH model, alert now, alert today, live tomorrow. It's fantastic. And that sort of really thumbs up the role of preparedness. But the pandemics and the outbreaks in general really expose what happens when we don't take a rights approach or gender equity are sidelined. And building community and trust and participation from the outset is as critical as delivering vaccines or making sure there's oxygen in a response. And this work that you've all been contributing to for PPR literacy is the place where we can empower communities to shape decisions and not just to follow them. And that access to timely, accurate information turns communities into the co-creators of resilience. And again, I really like or flag the example Kenya has and really being deliberate about the community's role in that data collection and the discussion around going on a day-to-day basis and feeding that information back into the system. And our future efforts must, of course, continue to include communities in the platforms and those national PPR platforms and inclusive funding mechanisms like the Pandemic Fund. As we move today from being communities as responders, we're moving towards communities being planners. And this is a really important part of what this work is contributing to. So we've had the examples given today where we've had regional TB networks helping to design the national community engagement plans, and then building on that PPR coalitions with the more marginalized groups and national platforms. Shaping community priorities in joint external evaluations and your national action plans for health security process are really critical points as part of the overall planning and preparedness process. Creating that open dialogue space with the Ministry of Health and Public Sector. Again, all of the examples shared today and across Cambodia, Kenya, Sierra Leone, Liberia are really good examples and different ways and approaches that it can be done, and that context matters. And finding the right platform and the way to engage for your communities in your context, in your country, is a really, really important part of preparedness. And so where do we go to from here? Preparedness is only real when it reaches the people who live it. So as we think about, and as we sadly have to close our COPPA funding as it comes to an end at the end of this year, how can we use this and build on and continue to fund this through our grant cycle 8 from the Global Fund? So investments through the RSSH and community system strengthening modules and interventions. So we really encourage that continued active voice to keep those priorities as part of GC8 processes and funding requests. The role of regional learning hubs and our collective support here to continue to share these lessons that we've had from COPPA and continue to sustain those partnerships with the National Public Health Institutes, the Ministry of Health, and the global actors makes this engagement not just a one-off but structural. And to really continue to encourage civil society and community networks to stay active in a PPR space, to advocate, to influence, and co-design the next wave of preparedness. And we know and appreciate when communities lead, preparedness works. So I really want to give, again, a really big thank you to everyone on the call today, your insights, your valuable expertise and sharing that. I mean, this has been, I've just loved today's conversations and hearing all of the work that's going on the ground. I'm still like so impressed by Kenya and your ability to set up a National Public Health Institute within the space of 4 or 5 years. Amazing. It is a really difficult thing to do. And I echo the comments in the chat about that picture of all of the functions under an umbrella. I think I'm going to like use that slide as an example. It's such a clear way to explain all those functions. So again, thank you for all our COPPA partners and the countries that we've been engaging with and all our community partners. You are what makes a response. And so thank you, RJ. And I hope I didn't interrupt your flow, but please continue the discussion. And we will also continue to think here at the Global Fund how we can ensure we don't lose all of this valuable and critical work that's been done. And we'll be, really fighting hard internally to ensure those priorities can, remain funded and in grants. So thank you all. Thanks for today.
All right. Thank you, Anna, for those inspiring words. And definitely, I think all of the CSOs here can agree that they're very interested in terms of how this can be sustained and continued to be supported by the Global Fund. But of course, there are a lot of investments already made for civil society. And I think we're just seeing the gains now. That's why there's a lot of inspiring stories that we're also hearing from our country implementers. So again, thank you, Anna, and the Global Fund for your support on this. Okay, so I see that Emord is raising his hand. Would you like to ask a question? Maybe we can proceed already with the Q&A. Okay, if not, I'd like to call on Lizzie if she would like to ask this question live. Um, Lizzie, are you still at the call?
Yes, I'm still here. I'm not so sure which question, but okay. So
It
for
was
me,
about
was the one around the Kenya perspective. I mean, they've done amazing work, but in terms of data and research collection, you find out that most of the time communities were used to collect data, but rarely will you come back to present your findings to communities so that I see whether we are agreeing it's what is represented on ground or this is just make believe and cooked up data. So I'd like to know how that, because I know the presenter from Kenya insisted on trust and building trust with communities. I need to know how do they incorporate feedback in terms of going back to report your findings so that communities can also contribute and say, yes, this is true or this is not the true representation of what is going on ground. Yeah, so I think it would be great. I know there was another question I put down, RJ. I'm trying to recall exactly when we're talking about infodemics, and I appreciate that term being used. It's usually good that organizations like WHO, the NPHIs work to, like counter the infodemics, misinformation, disinformation. But the issue has always been they use such a technical term. For example, during COVID-19, it was so technical coming from WHO, and that was the only trusted source of information that it took AMREF Health Group CEO to go live on video and say, hey, if you're feeling like you're hot, if you're coughing, simple things for communities to understand. So I'd like to know, how do they incorporate community language in their when they're addressing infodemics? Thank you.
Those are very important questions, especially for CSOs. So, so maybe George can answer this. So there was this question on how do we make sure that the technical language get translated to more popular ways of reaching out to communities. And then the second one is how are the findings disseminated? So, George, go ahead.
Thank you very much, and thank you for the question. So basically, for our setting, once we have to do research, we have to use the gatekeepers, and we have to say what we really need to do. And basically, even if it's an outbreak investigation that you're conducting, once we get the demographic data, we are able to give preliminary reports to the community that this is what we see as a prelim report. So before we leave the community, we are able to engage the leadership in the community and tell them, we're seeing this number of people affected. This is what we are saying. But further analysis from the data will now reveal more details to this. And some of the studies that have been conducted in the communities, we've had even use of the media stations, the local dialect radio stations where the information is given in the local language, such that we are able to even inform before we conduct the studies, the results of the studies, probably the age groups affected, how to do preventive measures. So most of the time we'll try to use the local dialect radio stations or even media stations, and even use the community. We will still use the community health promoters to make sure, because the man households in the where they're given the work, they make sure that they are able to deliver the message in barazas, in the chief barazas, such that we are able to have some form of feedback back to the community, not just collect data and move with the data. And for scientific, probably colleagues, probably we shall do the publishing where they get the information. But for community-based, we go back to the chief, we go back to the gatekeepers, and we also give that report over.
Right. Thank you, George. So basically, it's good that you're sharing preliminary reports to the communities because that can also help them be empowered in terms of taking action and also making decisions. And I think it's also good that you're engaging local actors. So technically, when NPHIs have messages to share, another way of doing it, aside from sharing it directly, is through engaging community members themselves, local champions, and even local radio stations, so that it's already translated or much more understandable from their end. So thank you, George, for that. So for this segment, so I'd like to invite our country implementers, George, as well as if Dr. Gina Salem is still here, maybe she can also take on some of the questions. And I also understand that there are participants coming from Ministry of Health or even EANFI. So maybe you can actually also take on some of the questions or share your insights if you have answers to them. So now I'd like to pose this question coming from
Hello,
Sorry?
hello, hello,
Ah, Emard, you have a question?
hello.
Yeah.
Bonjour à tous. Allô, bonjour. Allô.
Okay, so I think we need a
On t'écoute bien,
translation.
Destin, on t'écoute parfaitement.
Merci beaucoup. Je suis le révérend Père Aimard Destin du Congo-Brazzaville, membre de la POALP et de la POSCO et représentant de l'association Aimard Jeunesse Infrastructure. Je vous remets la parole.
Somme, can you help me with the translation of that? I see also Paul raising his hand.
Je n'ai pas la traduction en anglais. Je ne maîtrise pas trop bien l'anglais. Voilà pourquoi, si c'est en français, je veux bien vous écouter. Parce que là, je reçois plus tout en anglais.
Okay. Somme, can you hear me? Maybe you can help with the translation.
Hi everyone, just to make sure that you are in the English channel because I can hear Some on the English channel. Thank you.
Okay. Maybe it's just from my end because it doesn't allow me to enter the English channel from as host. But yeah, if anyone can answer the question of Emard, anyone? Okay, so maybe we can park that for a bit until we get someone to answer the question. Yeah, so let's proceed to the next question. It's coming from Feline Salvador. So her question is, how might we transform digital health infrastructures to help NPHIs and PPR and other rising crises like mental health and non-communicable diseases? So it talks about transforming digital health interventions.
So let me try and answer that. So
Yeah, go ahead.
I think the first step is digitization of the reporting tools, because I think for our setting, currently we are developing digital tools for reporting because this will enable real-time reporting. And I think the other way is a holistic view because like for example, we had flooding in March, April, and May last year. We were able to involve psychologists as part of the team that was going to the field because people were affected. So they also needed psychological support. So I think one of the ventures that NPHI also need to look is going beyond the pandemics and epidemics and looking at psychosocial support. So as NPHI, we've been able to engage, and we're also having them as part of our teams when doing response. Over.
All right. Thank you, George, for that. Abdias, would you like to ask a question live before we go to the questions in the chat? Go ahead. Okay, so yeah, I see you're unmuted now.
Bonjour. Bonjour à tous. Je ne sais pas si vous m'écoutez. Hello.
Hello. Yeah. Yes. We can hear
My
you.
English is not also good. I must explain with French.
Yeah, you can ask the question, then someone will help us
Oui.
translate it.
En fait, je vous suis attentivement depuis le départ, mais ma question venait sur qu'en dites-vous de la considération des facteurs environnementaux comme éléments pouvant intervenir pour mieux solidifier ou structurer ce système de surveillance en santé publique, étant donné que ces facteurs environnementaux sont en eux seuls responsables de 24% du taux de mortalité mondiale et que dans la majeure partie des systèmes de surveillance en Afrique, elles ne sont pas prises en compte malheureusement. Ça, c'est la première question que j'ai.
Thank you for that question. So basically, the question was the role of environmental factors that can affect public health surveillance. So usually, environmental issues are not or factors are not considered. So anyone who would like to share their perspective on that? So any
All right.
experience? Yeah, go ahead, George.
So thank you. So from our setting, we use a One Health approach, and where we said a One Health approach is looking at a triad, like it's a three-phase where we're looking at the environmental factors, we are looking at zoonotic factors or the animal health factors, and we're also looking at human health factors. So when you go into the field, we make sure that we have our counterparts from the veterinary department, and we also have our counterparts from environmental department, such that we are able to address the whole triad and break the disease transmission. So that is the holistic approach, and that is what we're doing, having a One Health approach to outbreak response.
Yeah, but George, are the environmental factors integrated in the surveillance systems also?
So currently for our system, the environmental division is not in NPHI. So we have the reporting structure there is not quite. So we have to invite them but we do not have the indicators with us because they are now in a different state department from NPHI. But what has come to our end is zoonotic disease unit is with us, and the human health is with us. But we still have to work with meteorological department. We still have to work with environmental department. So it does not limit us, even if they are not in our house right now. It does not prevent us for collaboration working with the team. Over.
All right, that's good. And maybe later on, if there are next sessions, we can hear more in terms of how these were integrated in your surveillance mechanisms. Okay, so I'd like to go to the next question by Peruth. They were asking on the role of young people in improving participation and continuous engagement in the health sector. So maybe our country implementers can share how they mobilized young people in their PPR response and even engaging with the NPHIs. Maybe Shantorn would like to share or
Yes,
our
thank you. I think
implementers.
the engagement of young people is very, critical, to support the, PPPR. In our context, we are one member. One member is called YKP network, Young Key Population Network. It's a part of the PPR platform. So that's why we train them, and then they conduct like a cascade or step down training to their respective, youth, community youth member, and we also provided, technical support on, PPR outreach. So I think this is very crucial. Like I said, in addition to that, we also work with the Cambodian Youth Red Cross, meaning that the young people, from the government, not government, just like a Red Cross. The associate entity of the government, to join. We train them, and then they disseminate the message to their respective youth fellow. I think this is a very, very how to say important role, of young people in support of PPR. I think this is our experience from Cambodia, to how to say, to advance engagement of young people in the PPR. Over.
All right. Thank you, Chantik, for sharing your experience. So now I'd like to close already the Q&A. I think there are some questions that we might not be able to take on due to the limited time. But I'd like to thank everyone for actively participating in the Q&A. And before we close our last lessons webinar, I'd like to give a few moments to our coordinators from ACT AP and ACT Africa, Jeff and Rachel, to give us a few words. Yeah, either Jeff or Rachel can start.
Thank you
Jeff, do you want to go first?
Okay, sure. Very quickly. Thank you so much, everybody, for joining our last lessons webinar. It has been an amazing journey since we started April 2024, and we started our lessons a few months after that. Today, we had a total of 176 registrants and 85 participants at most, so that's a good number. But on the average, for the 12 lessons, we were able to at least around almost 94 participants attend every time. So thank you so much. Just a quick reminder, please do, if you wanna spread the word about Copper, even if the project is closing, the Copper website will remain. That not only contains the lessons webinars, but all the publications that we have. I'm supposed to show you some publications, but I'll take it as a surprise that the resources part will be at the bottom part of the website. Resources from the community-led surveillance to the PPR 101 to MPOX to establishing your Copper platforms at the country level. And we will also have a playbook soon. If other countries would want to replicate the process of Copper, we will also have that available on the website. So please stay tuned, and don't forget to join our WhatsApp as well. We will keep it open so that our collective journey continues. Thank you so much, everybody, and hope to see you again soon. Over to you, Rachel.
Thank you so much, Jeff. On behalf of the African Coalition on TB, I want to thank everybody for your constant participation in our webinars. There are some participants that have been on since the first webinar till the last webinar. And COPPA has shown that pandemic preparedness is strongest when communities and public health institutions work together. And so as we are closing COPPA, I'm believing that we are to carry forward the lessons that have come up from COPPA and ensuring that we strengthen the bridges between communities, government, and public health institutions. As Jeff has already said, let's continue engaging even though COPPA is coming to an end. Thank you so much, everyone, for being here.
Just a quick one as well. Let's give a big round of applause to RJ for helping us facilitate all the lessons webinar. To all our interpreters, thank you so much for always being with us. Some, Windy, Bong Chong, thank you so much for helping us get through and having more participants. This won't be possible without everyone's help. It takes a community to prevent and prepare and respond to a pandemic. So thank you.
Thank you, RJ.
Thank you, everyone. And thank you, Jeff, Rachel, Olive, Rain, Francis, everyone who's actually guiding this whole process. So I'm just implementing things, but really the brain work with this is really from our implementers.
And also to
And of
Olive. Let's not
yes, and
forget
Olive,
Olive as
of course.
well.
Olive, of
And the
course, she
Global
left.
Fund.
Yeah.
Thank you. Thank you, Olive, for your constant support with this initiative. And of course, for this
And the
lesson,
learning hubs.
Sorry,
The
Rachel?
learning hubs as well. The
The learning
Anglophone,
hubs, yeah.
Francophone Asia Pacific. This is a
Thank you.
bittersweet end.
And
I
of
hope you
course,
indulge us, everyone. But thank you so much.
thank you also to our speakers for this lessons webinar, George. Let's give him a round of applause. Also to our country sharers, Shantorn Prong from Cambodia, Paul Bangura from Sierra Leone, and Leotia from Liberia. So thank you for being so generous with your experience and also your and for giving us inspiration in terms of continuing what needs to be done for pandemic preparedness and response. So with that, I'd like to invite everyone for a quick photo opportunity. If you're comfortable, you can turn on your cameras and then we'll take a quick shot so that we can have this as our last lessons photo. And you can also, while we're waiting for everyone to turn on their cameras, you can also look at the evaluation form. Please do answer so that we can improve our next sessions if there are.
All right, let's do this. Ready? 1, 2, 3. Okay. One more. 1, 2, 3. And then one last. 1, 2, 3. Okay. Thank you so much, everybody.
Thank you.
Thank you, everyone.
And everyone. Bye-bye.
Please answer the
Rachel.
evaluation form. So we'll just open this for a few minutes.
Okay, disconnecting of hello.
Bonjour.
Okay, we'll be closing the room in a few seconds. Hopefully everyone was able to answer the webinar evaluation form. Okay, Jeff, I think we can already close.
Yep. Thank you so much, everyone.
Thank you.
Bye. See you again
Bye.
soon.
Thank you so much. Bye.